So let's just get going here. And what's happening? Okay, so maybe we'll talk about the Moria tree fine a little bit. We talked about how it comes in two pieces. You first have to open it up, and the first thing you have to do is wind back this knurled knob all the way to the end. So you go, it's counterclockwise. You keep rolling it back, and that reverses the whole carriage, so it's retracted as far as possible. And before you do any adjustments, if you don't do that, you'll lock the gears in the Moria tree fine. So back it up all the way, then turn it on its side, and you'll see a little square window. And you should see a number in that window. If you don't, you take the circular wrench. It's also got a little cutout window. You match up the cutout window with the cutout on the Moria tree fine, and then it'll click. You'll feel it go click, 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 click. And you may have to click it one way or the other to see the numbers. And make sure that the stem is locked. The stem being this part here over on the right hand side. If you don't lock the stem, then the gears can also jam. So you wind it back all the way, then you pull the stem out and you turn it and place it onto the little platform there, and that will lock it. And that way you'll see that if it's locked, you won't be able to turn the knurled knob. Then you will hold it with the cone facing upwards, and you'll place the blade. There's 3 little cutouts that match the cutouts on the blade. So first, look at the blade. It'll say, it'll have on it the number. So you want to check the number. Let me see if I can just draw this quickly. Actually, I could probably use the annotation feature on this program if we want to get fancy. But it'll look something like this.
Dr. Rootman, sorry, just a quick question. Oh,
yes.
We don't see it.
It disappears. How do you like that?
Yeah, that was funny.
Yeah.
It's just that the fellow that's coming for July, Nisar, he wanted to access the meeting, but he's not being able to.
Is he using the link that you sent in WhatsApp?
Yeah, the new one.
There's no
new one.
doorbell access. He's definitely not using the one from the email, right?
No. I just resend it again to him, but he tells me it says internal meeting only. So I don't know if you have it like privately only for us or.
I don't know how Prof set it up. I'm sorry. Let me.
Maybe yeah. Let's see.
Not a meeting.
Invitation.
And he should come into the waiting room, but he's not there.
Invite.
No,
okay,
he's
so
getting
what's
there.
What's his email? If anybody know his email?
Yep, it is Nisar
Nisar,
at doctors.org.uk.
Nisar dot?
Nisar Din, his surname D-I-N, there's no punctuation there, at doctors.org.uk.
Okay. Okay, sorry. That's okay. I just sent him a new invitation. So,
Thank you.
okay. So hopefully that'll get him into it. Okay, so let's see if I can use this annotate feature here. I should have practiced this before.
I don't know if we have annotation if we don't have webinar access. If this is a meeting, then we won't have annotation access. That's one of the limitations.
Well, oh, really? Let's see. Do you see a circle?
Yeah, that's cool.
Okay, so I guess we've got something anyhow. So you'll have like three things here that these are the flanges that match up with the indentations on the Moria tree fine. And I'll just do a quick circle here, and it'll say so that's a 7.5 millimeter tree fine. And so the first thing you should always do is check the blade, because usually we go 1/4 millimeter over size unless it's a perforation, or if it's an aphakic patient, then we'll go usually 1/2 millimeter, or if it's mushy tissue where you want to have a little bit extra. I guess, well, the other time I'll oversize is in pediatric cases, because you want to, those eyes tend to be very, very shallow, and you put in a lot of tight sutures because the tissues are thin. So you want to have a little bit more tissue there so it'll vault forward and stay out of the angle. So that's what the blades look like, and you place that in, and then you lock the blade in by turning the knurled knob on top of it, and then you'll place the cone together, the two pieces, and it's very high. Hi there, Nizar. Welcome. Great to see you. So it has very fine threads on it, so you have to be mindful that when you're screwing it on that you don't jam the threads. And it's a very nicely made device, but it's a little bit finicky. So you want to make sure that the threads go on nice and smooth, and then see that it's flush. You don't have to jam it really hard, but you just want to see that there's no gap, because if there is a gap, then your depth is going to be off. It's not going to give you what you want. Like 4 is 0.4, 5 is 0.5, etc. Goes up to 1.2. So that's assembling the tree fine. And then actually, before I assemble it, I'll often make an impression with the cone with the blade on it, without the external suction cone. So you want to just make an impression on the epithelium to see that it's centered. And if it is, then you can put together the rest of the tree fine. If it's not, you can use your central mark here to adjust it. So you'll look at the mark on the epithelium, and if you see it's too high, then you know that you, instead of making another mark, just remind yourself to go a little bit inferior to the mark to displace the tree fine a little bit. And you can do a partial thickness trephination, and the Moria tree fine is good, except if you've got a lot of chemosis, then it may not, you'll either get poor suction, or the depth of your tree fine cut will not be accurate. So let's just clear this, and we'll start the drawing again. Or sorry, we'll start.
What do you prefer, Prof?
Which do I prefer? That's a good question. I think the Hesperid Baron is a little bit easier to use than the Moria, but we did do a comparative study back in 1994, as I told you about last time, and found that our results were better in terms of astigmatism using the Moria tree fine. They're about the same in terms of cost because those blades are quite expensive. And we used to reuse them. We do because it's kind of doing a trephination on a cornea isn't terribly stressful for the blade, but because it's single use, most hospitals now won't allow you to reuse the blade. And this is creating a Hoffman pocket. You make a partial thickness cut down just anterior to the blood vessels if you can. Nazir, this gentleman, we talked about him last time, but he had a PK for keratoconus and got punched in the eye or poked in the eye by a family member, and ended up avulsing his lens and avulsing the graft. You can notice the old graft here, like so. So the first thing you can do is fixate the eye. I think it's probably better to fixate by grasping at the limbus, as you'll get better traction. Not at the limbus, at the edge of the graft, you'll get better traction, and then your blade will cut better. And it's important to go down to about 50% depth, and then you turn the blade parallel to the surface and do a superficial cut. Now, I used to do it like as I'm doing now, is you make the Hoffman pocket to go all the way back here. Make it to, at least that size, so that when you penetrate with the needle from the inside to the outside, you're in the correct place, which is about 1.75 to 2 millimeters posterior to the limbus. Maybe we'll just speed this up a little bit. I don't think I can speed this one up. Oh yeah, you told me that there's a way to do this, right? Under video.
Yeah, so go to playback.
Playback, yeah.
And then you'll have the speed there.
Does it make it jumpier when I do that?
I think there's always going to be a
little bit, yeah.
It naturally jump frames when it's going faster. But this is okay.
So now what we do is, instead of making a full Hoffman pocket, I would stop just to about there rather than dissecting back to 2 to 3 millimeters posterior to the limbus, because you can just tunnel the needle underneath the sclera and have it come out through the Hoffman, the partial Hoffman pocket. And I think it's less traumatic. There's usually less bleeding when you do that, and there's less chance of penetrating into the suprachoroidal space, as I did on the left-hand side here. So now we're just placing the Goldman McNeil speculum, and then we'll put the sutures on it. You just scrub forward a little bit on this. So put in 4 sutures, suturing from the limbus towards the, here I'm doing suturing from the limbus towards the periphery because the patient's aphakic, but in a phakic patient, you may want to suture the other way because there may be a risk of dinging the lens if you go in this direction. And it's important to pick up a bite of sclera so that you're elevating the eye up against the ring rather than just grasping the conjunctiva, which doesn't really do you much good. Okay, so now there's different ways to to preset your sutures. This is the way that I find is the best. You use a 27 gauge needle in your left hand and you bend it, put a almost right angle bend to it, or maybe 60-degree bend, and then you come with your right hand about 2 millimeters posterior to the limbus. Let's just get the next video here. Yeah, so now I actually take a caliper and I'll mark 2 millimeters to the limbus because I don't trust my judgment completely in terms of what 2 millimeters is, and it's important to have those entrances as symmetric as possible. And look what's happening here is we're getting a little bit of a hemorrhage, which doesn't happen that often, but it can happen, and you can end up with a lot of blood in the vitreous. And now I'll just do a bimanual vitrectomy. I think there was still vitreous up to the wound after the repair. So we're putting the infusion in through a cut, an entry point in the keratotomy to keep the eye inflated as much as possible, and then using the vitrector in our right hand. And what I found when we first switched to the Centurion, that was not a Centurion, by the way. That was probably the Infinity. And the Infinity vitrector is bigger, and it tends to be more efficient, whereas the Centurion is smaller. And I found that if you use the really high cut rate, that we just weren't getting any vitreous cutting. So I turned the cut rate down from 4,000 to about 1,500, and then it works quite efficiently to do an anterior vitrectomy. And here I'm trying not to obscure my scissors, and all those principles that we talked about before of keeping the scissors as much as possible at right angle, which is not happening up here. And you'll notice that there's a little bit of a ledge up here, and there's a little bit of a posterior ledge down there. Not terrible, but it's nicer if it's a nice clean vertical cut, 360 degrees, and you don't have to spend time trimming it, because what we're trying to do is minimize our open sky time as much as possible. And here we're doing the vitrectomy with the infusion in the left hand, vitrector in the right, or sometimes what I'll do is just do it without infusion, just do a dry vitrectomy to really scoop out the anterior vitreous. And if they've had a vitreous detachment, you'll likely do a fairly thorough vitrectomy. And then you take a dry Weck-Cel and just dab it around the edge of the iris to see if there's any more vitreous strands that are adherent to the front or the back of the iris. And this should be 9-O-proline. I'm pretty sure it is. It looks too heavy for 10-O. And you can tell also the 9-O-proline has it's only, I think, 9 or 10 centimeters, whereas the 10-O-proline is a longer suture. And this is the CZ 70 BD lens made by Alcon. It's got the little hole in the end of the haptic there, and you can thread the end through, and then you can do even 2-1-1 or even 1-1-1 is fine. You want to just get a good solid knot there, and try not to crimp the tissue, the suture. Like, don't squeeze it really hard, because then you'll have a point of weakness that can possibly erode through. And the nice thing about this lens is that it's big and it's stiff. It's 7 millimeter optic, a 13 millimeter haptic diameter, and you can pull the suture through and then do a nice square knot. And this is where, you know, technique is really important, that you should have a nice locked square knot so that you don't have to lose sleep over whether that knot is going to slip or untie. And sometimes I'll do 4 throws on it just for a little bit of insurance, and cut the end. In the circumstances where the cornea is totally opaque, you can either do a lamellar dissection, like we talked about for doing a phaco, or you can do this open sky, and rather than passing it from one side and then docking it in a needle, you can go underneath the iris, put your 0.12s on the outside where you want the needle to come out, and then push the needle through. So you can do it from the internal to the external. And oh, that was a quick video. Let's see the next one. And this is with the complete Hoffman Pocket. You have to go in with the Sinskey hook and then retrieve the suture. And now we have to secure this to the sclera. And what I'll do is I'll usually take the long needle and take a small bite of sclera on the internal bed. Actually, what I've done is here, that's a short, it's also a 9-0-proline, but it's on a short needle. So it's a little easier to handle it. And then I'll just tie it once to itself, like so. Just make a little knot, and then cut those ends off about 2 centimeters long, like so. And I'll then use the suture that's attached to the IOL that's come through the Hoffman Pocket, and I'll tie it to the two that little loop that I passed through the bed of the scleral pocket. Does that make sense? And you'll see it again on this side. Just grasping the needle and taking a bite through the base, and now tying it to itself just with one single throw, cutting it off, and now letting those two pieces stick together and using the single end as the tying suture. And, you know, there's lots of problems with sewing in lenses. You can have vitreous hemorrhages. You can sometimes incorporate the base of the iris, and you can end up with like an UG-like syndrome with chronic inflammation. You can end up with torquing of the lens, which I think is more common with if you use a 3-piece foldable lens. If you use these 1-piece lenses, they're very stable. The optic's large. If there is a little bit of a tilt, it's not going to create a great deal of astigmatism. But actually, the only time that I've had significant tilt is using the foldable lenses in a sew-in situation. So I think if at all possible, use a big PMMA lens that's got a nice rigid haptic. PMMA is still the most inert material that we've got. And I've got patients now that are many, many years with having undergone a triple procedure with the PMMA lens or with the sewn-in lens. And they really look good for longest period of time. that at least that I have on record. And now, just to emphasize the principles of suturing here, number one, you want to fold back the edge of the tissue, open it up like you're plying open a telephone book, so that you can judge the depth of your suture here, and then grasp. Generally, I like to pass the needle where I'm holding with the forceps. In that case, it was a little bit to the side. And now here's the, oh, sorry about that. Let's go back here. Let's just stop that for a sec. What you want to do is hold your needle holder parallel to the tangent of the wound, so something like that. So you want your needle holder to be parallel to the tangent of the wound, or perpendicular to your suture tract, and have the tip of your tying forceps going beyond the suture tract. So don't be wrapping it. Don't have your needle holder here, but rather have it like this. And then when you wrap with your left hand, pull it over to the right, and what that will do is it will it'll keep these wraps on your suture, or on your suture holder or needle holder, by pulling in this direction. You're then going to be holding those throws onto your needle holder, and also your needle holder will be in close apposition to the end of your suture. You should, I'm making a mess here. So let's see how well that worked out. And that's a pretty good suturing technique there. And you'll notice for the first suture, we did not lock it. It's not necessary. The only time you need to lock it is, let's say you're doing a keratoconus and everything's starting to bulge forward, then you may need to lock it. The 3 throws may not hold your suture tight. And if you're mindful of those steps, so one other step that is useful, or one other maneuver that's useful, is before you grasp the end that you've pulled through, flick it up a little bit so that it's standing up. If it's not standing up, then having a little bit of Helon or BSS on the tissue will often make it easier to pick up the suture. But if you haven't stood it up, then turn your needle holder on the side so that the opening of the jaws are parallel to the surface, and then you can sort of get underneath the suture and pick it up instead of trying to grasp it over top of it. And the other trick that I was taught by Sprague Eustace, who was a pediatric fellow when I was a resident, is that after your first throw, turn the needle holder over so that it's pointed downwards like that. And you'll also find that it's easier to pick up your suture. Now, we're going to talk about what happens when the graft gets pushed down below the surface. Sometimes it can be difficult for you to get it out. There's a couple of ways you can facilitate that. One is, first of all, turn your needle holder more on an angle. If you're going straight down with both tongs of your needle holder, or sorry, of your colibri, it's going to be difficult to pick up the tissue. But if you turn it on an angle like this, you can get one of the tongs below the surface, and then first thing you try is to grasp it. Second thing you try is to put the teeth into the wound and try and flick it up with the tooth, or elevate it enough so that then you can secondarily grasp it. If that doesn't work, sometimes what you have to do is go to where the last suture is and go in also on an angle with your forceps so that one of the tongs of your forceps goes below the surface of the tissue, and then just run it along to the center where you want to grasp it and lift it up. And finally, another good trick is you can stab the tissue with your needle. Just turn the needle over so that the tip is vertical to the surface, and then just give it a little push, like a little flick, and you can often stab it and then lift it up. And sometimes, you know, particularly in these vitrectomized eyes or the high myopes, they can be difficult. And I suppose lastly, you can fill the anterior chamber with some viscoelastic, go underneath where the suture is. After you've got 4 sutures in, usually I'll put in a little bit more viscoelastic. And the best way to do that is to come with your cannula vertical to the wound and go right underneath where the suture is, because that's the time. At that time, the wound is when you've only got 4 sutures, the tightest part of your wound is going to be right underneath the sutures. If you try and put your viscoelastic here, it's going to just, it may just come out. But if you go in vertically right beside the suture and inject, you'll often end up with inflation of the chamber and pushing the iris back. Does that make sense?
Yes.
Yes.
Yeah, definitely.
Okay, so in this case, it's not that important to inflate with viscoelastic because the eye's behaving well. We've got it sewn on with the ring. We've done a subtenon's injection, but haven't ended up with a huge hemorrhage. And let's go forward a little bit more. And that showed a nice way to dance the needle back and forth. I guess I finally gave up at that spot, but let's just back it up a little bit. We're having too much difficulty. So, you know, they talk about low-hanging fruit. So we just flipped the needle around and grasped it the other way. And generally try and avoid touching the needle as much as possible. That's why I don't pick up the needle with my colibri and then try and position it. I generally will dangle it. And here now, in that instance, with the forceps on more of an angle, like about a 45-degree angle, you can get one of the tongs of the forceps underneath the edge of the graft and then get your suture done. Okay.
I know that we discussed previously about the demarcation of where your sutures are going to be placed. Is there a reason that you prefer to do it like eyeballing it than using the RK marker, or?
Yes, there is. There's in eye surgery, there's a reason for everything you do. If you don't know what the reason, if you think there's no reason, you just haven't thought hard enough about it. But yes, there definitely is a reason. Um, what I found is that using the RK marker, if you're a little bit off with the RK marker, then your 8 marks are going to be off as well. And then if you mark your donor as well with the RK marker, now you've got 2 marks that are a little bit off, and you're compounding the error. So I find that, you know, corneal surgery is all about symmetry and bisecting spaces and bisecting circles. It's fairly easy to see the 6 and 12 o'clock position, because usually in most patients that's the narrowest spot, and you can then divide the cornea in half, and then look at your 2 spots and divide each of those 2 spots in half, and then divide the space in between your other sutures in half. And I think that is more likely to get you. And then you draw your imaginary lines between the opposite spots to find the anatomic center of the cornea. And you know, we actually, come to think of it, with working with Gilad, we designed. He has a marker for that tree find, or not for the tree find, for the keratoprosthesis. So I said, you know, that marker would be really good for our purposes as well. And this is the marker that they came up with. It's a 3D printed version, and I haven't had a chance to use it. I don't know, I guess keep forgetting to bring it. But the advantage of it is that it's translucent. You able to see it? It's translucent. So you can, you know, put it onto the cornea and still see what's going on underneath it. I find the problem with the RK markers is you've got, especially if you put ink on it, you've got 1 chance. And if you mess it up, which I have a good tendency of messing those things up, then your marks are going to be off. And before you know it, you've got this big, confusing blue blob of marks. So I have to remember to bring this in, and we can probably use it at Kensington. The Western will never let us use it, but we'll get it sterilized at Kensington and try it out there. And I think that this could be helpful. And we'll all become millionaires on the royalties from selling it. So. You know, we're all looking for an exit, right?
I guess.
I'm looking for an exit from the home. From home. This is the exit that I'm looking now.
Most important one, yeah. Well, get a dog, then you've got an excuse. The kids, they'll play with on the computer or whatever, but the dog, he starts to go nuts in the house. So it gets you out.
Netta would probably call first dibs on the dog in that case, and then they all would still be in the same mess.
Yeah. So, Gisela, were you able to find what we were going to look for? Not for a running suture, but for something else. Oh yeah, the short Hoffman pocket. But really, the short Hoffman pocket is the same, only easier. You know, you just you don't do the dissection as far back. Then you'll take your long needle and try and go through the conjunctival opening that the needle has come out, and then just tunnel it along the sclera and have it come out in the short Hoffman pocket. And I think that it's easier and you know, causes less bleeding as well. Okay.
I have a question, but then you suture it the same way like you showed us before? It's like the same way?
Yeah.
You're taking it through the pocket again and tying the... Okay.
Yeah, you just take a bite of the base of the pocket with either that same long needle, or you get the short needle. It's TG140 dash something or other, TG140 needle. It's longer than and bigger than the TG160, which is the Ethicon 10-0 nylon needle. And I guess in theory, you can even use a 10-0 nylon suture, because all you're trying to do is have it there long enough that you get some fibrosis. If you create a little knot there, it's going to get stuck in the tissue eventually. So that's the way that that's been my evolution of sewing in lenses. There's a couple other modifications that I've played around with. We had what's his name visiting us from Naharia. You know, he's coming for a fellowship the year after. Forgotten his name for the moment. At any rate, his boss, there's a needle that's produced in Japan. It's a single long needle. I think it's Japanese, or it might be Indian. And then it's a loop of 10-0 proline. So he ties the loop to the haptic, then passes the single needle, and then without even making a pocket, he passes it forward, does a paracentesis close to the limbus, and passes the needle out, and then cuts the needle off and ties those two ends together. I think I like the mini Hoffman Pocket better, because then you don't have a full thickness penetration of this paracentesis that's serving no other purpose than to hold the suture. And the other discussion point,
do you want me to play the other Hoffman Pocket one? I have
Sure.
Also
okay.
The one that you did for Borsuk, the patient that also had a PK the day before. I don't know if you remember that one.
He had an RK. Oh no, he was the Keratoplasty.
Yeah.
Sam
So
Borsuk.
we did IOL. He was aphakic. We placed an IOL in the sulcus with a PKP the same day, and then in the same day post-op, his lens was not there. So the day after that, you did a Hoffman Pocket, like a mini Hoffman Pocket.
Right. Have you got it there?
So Gisela, just see if you can hit share screen. Prof, you may need to make her a co-host to be able for
I
her.
can't. I just tried, yeah.
Yeah, so if you can just make
Okay.
Gisela a co-host, she should be able to share her screen.
Okay, you should be co-host now. I guess I can stop share my screen. This is that brand new Zeiss system that we've got at.
Great camera.
Yeah, yeah, that new microscope is incredible.
Yeah.
And the whole video system.
So did you go back to OR the next day, Gisela, did you say? I didn't hear about this story. Gisela, you've muted yourself.
Gisela, are you there?
I'm gonna now. Yeah. Can you hear me now?
Yeah, I can hear you now.
Sorry, yeah. I'm not an expert with this. Anyways, so yeah, so actually we normally don't see PKPs the same day, but he's from super far. So we saw him the same day, and it was like, oops, that lens is not there. Like during the surgery, we thought he had good support, but no, it was gone. Okay. So I don't know if you want me to play it fast forward. I didn't have time to edit it, but or you just want me to let it roll.
Yeah, sure.
Like this?
Yeah, you can
tell us the story.
So here you're suturing the lens here, like you went with the needle through the opening of the ZZ lens, and I'm gonna just play it a little bit faster. so that we get to see most of it. And then we cut that end and tied it on the opening of the lens, on the, how do you call that part that's like
The eyelet.
loop?
The eyelet.
That's an appropriate name. So I tried maneuvering this without, I think I tried to sew in the lens that I'd put in there before, or was this the same lens? I can't remember. I think.
No, we changed the lens, but you tried without opening the PKP, and I just played the video in the one. You decided to just open the PKP and just use that as a wound to enter the lens, because it was being very complicated to see because the graft had 1 day. So it was very swollen and it was really hard to like do all the manipulation intraocularly. So you decided to just open, as you can see, 180 degrees of the wound and suture the lens outside and then just enter it through the PKP opening.
Prof, when you're trimming the short end after it's gone through the eyelet, do you like aim for 1 millimeter as short as? Do you try and leave a little bit so if it comes loose,
I usually leave a little bit, yeah, like a millimeter and a half, 2 millimeters. I don't think I've ever had a problem with irritation. You know, I've got an 11 o'clock appointment, so why don't I let Gisela narrate this? Are you comfortable with that, Gisela?
Yes, thank you.
Yeah, okay. So why don't you, you can go as long as you like, but I've just got to, I'm on a tight schedule today. I'm so busy. I'm so busy.
So, Prof, are you on a Zoom meeting at 11?
No.
Okay, good. Because I was going to say, then we have to shut this because you won't be able to use it.
No Zoom meeting at 11. Okay.
Thanks so much.
You're welcome. So we'll see you next week. Okay.
Thanks, Prof.
Thanks, Prof.
Thank you very much.
Bye.
Okay, so I don't know if you got that part where he entered through the PKP opening and externalized the needle posterior to the limbus to your left. Did you see that?
Yeah.
Okay. So here, I don't know what happened. He's gonna do the same thing again.
A little bit, yeah, I think so. That's okay. So
okay, he's just tying the proline to the other haptic. Sorry, can you repeat the name of this little part of the haptic?
Yeah, sure. It's called the eyelet, like I and then L-E-T, like a little, like piglet or.
Okay, eyelet.
And
I guess he's now going to.
So was this same day, Giselle? Like, did you take him back to theater?
No, next day because we saw him at 4 or something. Okay. So he had to stay an extra day. It was such a big deal. Anyway, but then the next day he did this and then he was okay. Because imagine if he came the day 1 and we just find out. Fortunately, we had an hour the next day for some crazy reason.
Yeah.
But anyway, so here he's going to try to go with the other end and do the same thing. So put the proline through.
So he didn't do pockets for this case then?
Yeah, he did. So
he did it reverse. Okay.
Yeah. So let me show you. So now he's going to enter the lens through the opening of the PKP. Now that both ends have been secured with the proline and the proline suture has been externalized. Because what he normally does is that he uses a needle to guide the entrance of the externalization of the proline one. But here he didn't do that. Is it running okay?
Yeah, it's running well.
Maybe if I make it bigger. Is that better?
Still good.
It's the same? Okay. And now he's gonna do the pocket, I think. Just gonna forward it a bit more while he sutures the PKP part. Because I guess he wants some stability before he does the pocket, because you need like the eye to be firm in order to be able to create the pocket.
So he was waiting with the pocket only after he entered the lens in?
Yes, like
Okay.
here. So now I'll play it now.
Yeah.
Here you
All the
go.
way around. Yeah.
Mm.
Usually he does the pocket, he's doing the pocket at the
And that's-
cornea. And
That's
not
what we're
really at
saying.
the,
That, yeah. He's changed his technique like 3 times, I think, in the last 6 months. So it's good to have a look at the range.
but this one is actually limbal pocket. It's not as cornea, because when I saw him doing it,
That's
he
what we're saying.
entered actually at the cornea.
Yeah.
No, this is how I have seen him doing it.
Okay.
Yeah,
But
yeah,
it's
that's
just
what I mean.
very,
Like, it's changed a lot in the last year or so.
Yeah.
Yeah.
but you see, it's very little. It's not like the previous one he showed. It's like a full 3 millimeter pocket. This one is just very tiny. And then he comes with the Prolene and comes out through that. Let's just see what he does. I don't want to anticipate and make a mistake.
It's good to see the range of modifications of that technique.
So he goes in like really close to where he came out, and then he comes out through the little pocket he just made. Does it make sense? What I'm trying to say?
Yeah, sure. Yeah, yeah. This is exactly what he's doing.
Yeah. I was just saying that normally he'd go into the cornea a little bit because the incision would be more corneal. So it basically is a longer pocket, basically. That's all.
Mm-hmm. And then he does another pass.
Through that one.
I think this,
Inside
I mean,
the
I've never
pocket.
done it myself. I don't know, Tanya, that you've done it. Like, how hard are those needles to manipulate those needles? Because they're so large as opposed to what we normally use for.
Yeah, it's actually good because you have enough stiffness, because sometimes you're operating, like in this case, with a fairly soft eye. So they're actually not too bad to manipulate. You want, like, you've got good stability and you can get a really good bite, because if you think about the length of the pass through the Hoffman pocket, you need a longer needle to do that. You could not do this with a tiny one because you won't get the length of your pocket through and you'll lose your grasp.
And this is how he ties it down. And then the knot will be like.
So he is tying the loop.
He created the loop and then he just ties
Yeah.
over the loop. He didn't cut like he did in the previous video.
Yeah,
I've never seen him cutting the loop. He just ties on top to that loop.
And then cuts close-ish to the knot and then pushes the knot into the pocket.
Into the pocket, exactly. Exactly.
But you can do that here, AL, but you can't do that so much when he's more corneal, because you can't tuck in that way. You have to loop back into the pocket.
Mm.
You know what I mean? Like, you can't stuff the knot in the cornea bit.
Mm-hmm. Is that
But
I haven't seen him doing it so corneal, so I don't really understand.
You'll see.
Yes, sometimes you can even see the knot inside the cornea.
But I don't remember seeing him stuffing it inside. Like, the knot always ended up quite more limber, but you'd see a loop in the cornea. That's what I remember. Yeah.
Mm-hmm.
Yeah.
Oh, okay.
Yeah.
Then he did change it. But this is what he means by the mini Hoffman, right?
Yeah, I think so.
Yeah, yeah.
Because for a
And
while,
then in this side is the same, but it's very different than what he showed, because he went into the pocket, took the loop out. I think this is much simpler, much easier. So he's gonna do the same thing at the other side. It's just sometimes those prolines start like coming out from the pocket when you see them post out. So sometimes I don't know.